Good afternoon, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Arati Nayak, ma'am. And let me share some of the achievement of ma'am. Ma'am has done MD, FICOG, FMAS, FICMCH, Diploma in Urogynecologist, Senior Opsi and Gynae, and Specialist in BMC Medical College, Bhubaneswar, Odisha. And today, ma'am is going to discuss on a topic menopause management and hormone replacement therapy, that is HRT. By taking not much time, I would like to invite ma'am and hand over this session to ma'am. Over to you, ma'am. Kindly proceed from here.
Good afternoon, all. Respected all doctors and delegates present over here. Well, thank you, IJCP, who have given me this opportunity. Today, my topic is menopause and its management. Menopause is degeneration of ovarian follicles due to uh, it is cessation of menstruation due to degeneration of ovarian follicles. Before going to the topic proper, I want to highlight little bit of endocrinology and etiopathogenesis. Menopause occurs due to gradual diminution of ovarian follicles. There is rapid decline in ovarian follicles between the age 30 to 40 years, and which continues up to a point when menopausal ovary is completely devoid of these follicles. Due to influence from higher center, the median arcuate nucleus of hypothalamus produce gonadotropin releasing hormones in pulsatile manner, and which acts over the pituitary receptors. And from pituitary, there is release of tropic hormones, that is FSS and LS, and which acts over the ovary, and from ovary there is production of ovarian steroidal hormones, that is estrogen and progesterone. This estrogen and progesterone have got both negative and positive feedback effect on pituitary. Ovary also produce inhibin, but it has got only negative feedback effect on the pituitary. In the initial part of menopause, what happens? There is low concentration of inhibin, so there is no more negative feedback effect of this ovary on the pituitary. So there is monotropic rise of FSS concentration, and which accelerates the follicular phase of menstrual cycle and causes high basal estradiol and menstrual irregularity. In perimenopausal women, what happens? The estradiol level fluctuates with FSS levels, and after menopause, granulosa cell gradually lose their ability to produce estradiol, and AMS level decrease markedly and progressively. So one of the major symptom of menopause is vasomotor symptoms, and the cause remains an enigma. There is some dysfunction at the level of thermoregulator nucleus of hypothalamus, and women who experience this vasomotor symptom have got narrow thermoregulatory zone, and who is the culprit? The estrogen withdrawal is the culprit, and rapid fluctuation of estrogen level is also responsible for these vasomotor symptoms. Sometimes alteration of neurotransmitter, that is norepinephrine and serotonin, also responsible for this vasomotor symptom. Menopause related decline in estrogen lowers the hypothalamic presynaptic alpha 2 adrenergic receptor concentration, and that leads to increased norepinephrine concentration and serotonin. Actually, what happens? There is sudden wave of heat with sweating that spreads over body, particularly in upper part of body and face, and increased skin temperature due to peripheral vasodilatation. 5 to 9 minutes after this hot flush begins, the core temperature declines due to loss from perspiration and increased peripheral vasodilation. Another issue with menopause is osteoporosis. The peak bone mass of bone occurs between 25 to 35 years of age. And after 35 to menopause, there is loss of around 0.4% of bone per year. And from menopause to 10 years, there is loss of around 2 to 3% bone per year. And after that, bone remains static. As all of you know that bone is a living tissue and dynamic tissue, there is a good control between osteoblastic activity and osteoclastic activity. and which is known as receptor activator of nuclear factor ligand pathway, popularly known as Rankel pathway. During reproductive period, because of high concentration of estrogen, the osteoblastic activity is more prominent, so more formation of bone. But during perimenopausal and menopausal period, because of less estrogen level, the osteoclastic activity is more prominent, so there is bone resorption. Uh, the changes in the lower reproductive tract during menopause, normally there is presence of estrogen receptor in the bladder, urethra, pelvic floor, musculature. Without estrogen tropic influence, vagina loses collagen, adipose tissue, and ability to retain water. As vaginal wall shrinks, ruga flattens, vagina attains smooth wall, pale pink appearance. Vaginal pH become alkaline and less hospitable to lactobacilli and are more susceptible to infection by urogenital and fecal pathogen. The prevalence of bacterial vaginosis is increased to 38%. The subcutaneous fat at labia majora lost, leading to shrinkage of clitoral prepuce and urethra. There is slight increase in stress incontinence and urge incontinence may be due to shortening associated with atrophic changes. So there is dryness, burning, irritation, and absent lubrication, and there is dyspareunia. The worst thing that happens during menopause is weight gain and fat distribution. Women aged around 45 to 54 years have got significant greater increase in weight and hip circumference. And because of weight gain, there is fat deposition in abdomen, and that causes visceral fat deposition, and that causes insulin resistance and subsequent diabetes mellitus. The dermatological changes include hyperpigmentation, wrinkling, and itching that occurs due to lower concentration of collagen, decreased sebaceous gland secretion, and loss of elasticity and decreased blood supply. The dental changes includes increased cavities, decreased salivation and sensation, tooth loss due to oroalveolar bone loss. There is the reduction in volume, tissue density, and of breast because of decrease in concentration of estrogen and progesterone. Sleep dysfunction and fatigue. Uh, there is direct relationship between hot flushes and impaired sleep. Decrease in quality of sleep, and which is easily awakened by pain, sound, and bodily urges. Loud snoring can follow partial upper airway obstruction that sometimes leads to obstructive sleep apnea. There is decline in memory, and that has no correlation with estrogen deficiency. Progesterone and sex hormone binding globulins are more positively associated with global cognition. Coming to the psychological changes, menopausal transition is a complex social, cultural, as well as hormonal event. The risk of depression increases to 2.5 times due to fluctuation of hormones, and which is more common in surgical menopause. Dyspareunia and sexual dysfunction. There is decrement in all aspects of female sexual function. Urogenital problems, prolapse, incontinence are other causes of sexual dysfunction. Significant psychosocial and physiological changes occurring simultaneously, like arthritis, hip, and lumbar joint pain. Then the silent disease, that is osteoporosis, that occurs during menopause. Osteoporosis is a systemic skeletal disorder which is characterized by low bone mass, microarchitectural deterioration of bone tissue leading to bone fragility and consequent increase in fracture risk. The spine, hips, and wrist are common sites of bone fractures from osteoporosis. It leads to the porous bone, and that is compressible like a bone. The incidence of osteoporosis is more common in female, and the ratio between female to male is 6:1. Types of osteoporosis. There are two types of osteoporosis. One is primary, another is secondary. Primary is again subdivided into type 1 and type 2. Type 1 that occurs in postmenopausal lady. Type 2 is age-associated osteoporosis. And secondary osteoporosis is caused by an identifiable agent or disease process or inflammatory disorder or bone marrow cellularity disorder. So, coming to the clinical signs and symptoms of osteoporosis, osteoporosis is often called the silent disease because unless a patient have fracture, it is not diagnosed. And fracture caused by osteoporosis are often painful, and there is back pain that can be acute or episodic, low thoracic and high lumbar pain. There will be decrease in height, kyphosis, Doger's hump, and decreased activity tolerance. There are some risk factors, some non-modifiable risk factors, and some modifiable risk factors responsible for this osteoporosis. The non-modifiable risk factors includes advancing age, female gender, premature menopause, surgical menopause, and family history of osteoporotic hip fracture in first degree relative. And the modifiable risk factors includes low calcium intake, low vitamin D intake, cigarette smoking, sedentary lifestyles, excessive alcohol intake, excessive calcium intake, low body mass index, estrogen deficiency, and recurrent falls. Coming to the physical examination, there will be loss of height, kyphosis, humpback, tooth loss, and decreased grip strength. There are two tests are there to diagnose this osteoporosis. One is occult thoracic vertebra fracture test. Another is occult lumbar vertebra fracture test. In occult thoracic vertebra fracture test, the woman is asked to stand by the side of the wall. Normally, there should not be any gap between the occiput and the wall. If there is a gap between the occiput uh, and the wall, then the occult thoracic vertebra fracture test is positive. In occult lumbar vertebra fracture test, if more than two fingers introduced between the rib cage and the pelvis, then occult lumbar vertebra fracture test is positive. Then what is FRAX? It is fracture risk assessment tool. It is a assessment tool used to evaluate the 10 years probability of hip and major osteoporotic fracture risk that integrates clinical risk factors and bone mineral density at the femoral neck. If the risk is less than 10%, thus it is low risk, and between 10 to 20%, it is medium risk, and when it is more than 20%, it is of high risk. Then what is OSTA? That is osteoporosis self-assessment tool for Asians. It is a simple clinical screening tool based on age and weight for postmenopausal Asian women. Women in the high risk category and those in the moderate risk category with additional risk factors for osteoporosis should be recommended for DEXA scan. This graph shows that with increasing age, the risk of fracture increases. Bone mineral density test, it is the most common test. The results are expressed in T scores. T scores are relative to how much higher or lower your bone density is compared to that of healthy bone. In case of healthy bone, the normal bone mineral density is more than -1. And in case of osteopenia, the BMD is between -1 to minus 2.5, and osteoporosis it is less than minus 2.5. For early diagnosis, we are advising X-ray, BMD by photon absorptiometry, quantitative CT scanning, quantitative ultrasonography, and bone turnover markers. Radiography, it is highly subjective. Unless bone less more than 30%, it cannot be visualized by X-ray radiography. Photon absorptiometry, either single photon absorptiometry or dual photon absorptiometry is used. Quantitative ultrasonography, it is non-invasive, low cost, less operation skill is essential for diagnosis. Lab test, we can advise ESR, bone profile, that is serum calcium, phosphate, albumin, alkaline phosphatase, renal function test, and plain X-ray that is lateral thoracic, lumbar spine or hip. So what are the goals of physiotherapy management? The goals are to educate proper posture, to teach safe ways of moving and lifting, to prevent a decline in bone mass and prevent fractures, to increase the strength in the bones, and to maintain or improve balance, to improve flexibility, to help decrease the stress placed on the bones by tight muscles. Then what keeps bone healthy? For healthy bones, we have to do exercise regularly. We have to take adequate amount of calcium, that is 1200 milligram per day, and adequate amount of vitamin D, that is 400 to 800 international unit per day, which is essential for absorption of calcium. And we have to do flexibility exercise that help in stretching muscles, protect against injury, and allow the maximum motion for joints. So, what is the guideline that is given by National Osteoporosis Foundation? According to this foundation, we have to counsel all women on risk factors for osteoporosis, perform BMD test for all postmenopausal women with fracture, recommend BMD in less than 65 years women with one or more risk factors, and all women with age more than 65 years. Then coming to the treatment, there are hormone replacement therapy, there are some drugs, and another thing is emerging therapy, that is new physical therapy program combines the use of a device called spinal weighted kyphoorthosis. The drugs includes bisphosphonates, raloxifene, that is selective estrogen receptor modulator, calcitonin, and teriparatide. The slide is not visible. Uh, there are some anti-resorptive drugs, there are some bone-forming drugs, and drugs with complex mechanism of action. The anti-resorptive drugs includes bisphosphonates, selective estrogen receptor modulator, hormone replacement therapy, tibolone, and calcitonin. And bone-forming drugs that includes teriparatide, that is parathyroid hormone, and drugs with complex mechanism of action that include vitamin D and strontium. Bisphosphonate is the mainstay of treatment for osteoporosis, which is approved by the USA. There are different preparation of bisphosphonates are available in the market that includes alendronate, recidronate, evandronate, and zoledronate. Then how to be taken this bisphosphonate? Bisphosphonate should be taken in empty stomach, in upright position, with full glass of water, and the ladies insisted not to lie down for at least 30 minutes after taking this drug. And what is gaining importance is intravenous zoledronic acid or Eclast. This intravenous medication is once a year for 15-minute infusion, which will allow the easiest available intake of an osteoporosis medicine with excellent efficacy and good safety profile. However, we have to do serum creatinine before infusing these drugs. Calcitonin is a medicine that slows the rate of bone loss and relieves bone pain. It comes as a nasal spray or intravenous preparation. The nasal spray causes sometimes nasal irritation, and the injectable forms causes nausea. Hormone replacement therapy, it is no more used to prevent osteoporosis. Estrogen is essential for healthy bone, and when the production of estrogen is reduced in postmenopausal women and in some pathological condition like following radiation or following chemotherapy drugs, the new study observed that one way estradiol helps to maintain bone density is by stopping the activation of an enzyme caspase 3, which is the central player in initiating the process of apoptosis or programmed cell death of osteoblasts. So, what is the Australian guidelines for osteoporosis? According to these guidelines, women under age 60, we can use hormone replacement therapy for osteoporosis treatment when the risk factors for thromboembolism, for cardiovascular disease, for breast disease, for stroke is less. When bisphosphonates and selective estrogen receptor modulators are not useful. But when the age of the lady is more than 60 years and the risk factors for cardiovascular disease, thromboembolism, and stroke are very high, in that situation, we cannot use hormone replacement therapy for treatment of osteoporosis in postmenopausal. Give drugs like bisphosphonates, selective estrogen receptor modulator, and strontium. Parathyroid hormone, that is teriparatide, is approved for the treatment of postmenopausal women who have severe osteoporosis and are considered at high risk for fractures. Raloxifene, it can reduce the risk of spinal fracture by almost 50%. And the important side effect of this drug is deep venous thrombosis. So, women taking estrogen, we have to do routine mammogram, we have to do pap smear and pelvic examination. Then, how to prevent this osteoporosis? For that, we have to do exercise regularly by doing walking, running, skipping, jogging, etc. And add soya in diet. Avoid smoking, it can reduce the levels of estrogen and increase bone loss. And avoid excessive alcohol intake. What is the 2019 guidelines for Endocrinal Society for Osteoporosis? According to this guideline, that treat patients who are at high risk, particularly those with previous fracture, and consider bisphosphonate as the first line therapy for postmenopausal women who are at high risk for fracture, and reassess fracture risk after patient has on bisphosphonate for 3 to 5 years. Consider anabolic therapy for women at very high risk for fractures, including those with multiple fractures. What are the lifestyles and home remedy? Maintain good posture which involves keeping the head held high, chin in, upper back flat, and lower spine arch. Helps to avoid stress on the spine. And when sit or drive, place a roll towel in the back. Don't lean over while reading or doing handwork. Then HRT, I'll take another 5 minutes to describe about HRT. Hormone replacement therapy is a treatment used to relieve symptoms of the menopause. It replaces the female hormones, that is estrogen, at a lower level as you approach the menopause. HRT includes a wide range of hormonal products, that is estrogens, progesterone, androgen, and tibolone, with various methods and routes of administration and potentially different risks and benefits. According to International Menopausal Society, HRT should be a part of an overall strategy for maintaining the health of a peri and postmenopausal woman. It must be individualized and tailored according to the symptoms of the woman. What are the current indications of this HRT? We can use HRT for menopausal symptoms where the risk benefit ratio is favorable in fully informed women. And women with premature and early menopause until the age of natural menopause around 51 years, even if they are asymptomatic, and women under 60 years who are at risk of an osteoporotic fracture and in whom the drugs like bisphosphonates and selective estrogen receptor modulators are less value. Then what are the types of HRT that is available in the market? We can give unopposed continuous estrogen, that is estrogen only HRT when the uterus is absent. And we can give cyclical estrogen and progesterone preparation, that is combined sequential, when the woman is still menstruating and last menstruation has occurred within 1 year. We can give continuous combined estrogen and progesterone preparation, that is known as combined continuous. It is given in perimenopausal women when last mens has occurred beyond 1 year. And we can give continuous estrogen, cyclical progesterone, and we can give local estrogen. Different routes of preparations are available: oral, transdermal, vaginal, and nasal spray. The standard dose of conjugated equine estrogen is 0.6 to 5 milligram. A commonly used drug, that is estradiol valerate, the standard dose is 2 milligram. If a woman on HRT, if there is heavy bleeding or irregular bleeding, then the dose of progesterone is increased, or the duration of progesterone is increased from 10 days to 21 days. Normally, there is erratic bleeding occurs between first month to 3 months. But if this erratic bleeding occurs beyond 3 to 6 months also, then it needs evaluation. We have to do transvaginal sonography to know the endometrial thickness, and we have to do diagnostic histoscopy and endometrial biopsy for this erratic bleeding. Women with progesterone side effects like fluid retention, mood swings, and weight gain, then we can use safer progesterones dihydrogesterone. We can use micronized progesterone, and we can reduce the doses of progesterone and reduce the duration of progesterone to 7 days instead of 21 days. Then what tests are needed before starting? First, we have to ask the age of the patient. We should not use after the age of 60. And we have to take detailed medical history, and we have to ask what is the year since menopause, and see what are the relative and absolute contraindications of for this hormone replacement therapy. We have to do physical examination like breast examination, pelvic examination, baseline investigation. We have to do pap smear. We have to do mammography, DEXA scan, and vitamin D estimation. Sometimes lipid profile also. And if you are suspecting thromboembolism, we have to do thrombophilia screening. So when should we call the patient for follow-up? No, normally the response starts after 1 month, but maximum response occur after 3 months. So first follow-up is done after 3 months, then every 6 to 12 months once titrated. And breast and pelvic examination should be done yearly. Mammogram also should be done yearly. And endometrial biopsy if it is essential. There are some estrogen related side effects, some progesterone related side effects. The estrogen related side effects include nausea, headache, indigestion, and skin irritation. The progesterone related side effects includes fluid retention, bloating, depression, and mood swings. What are the risks associated with HRT? The most important risk factor associated with HRT is cardiovascular, that is venous thromboembolism, pulmonary embolism, coronary heart disease, and malignancy. Sometimes it causes breast cancer when combined estrogen and progesterone preparations are used for more than 5 years, and endometrial cancer when estrogen alone preparations are used and when uterus is present. And there is increased incidence of Alzheimer's disease, and there is increased incidence of gallbladder disease. There are some short-term use of HRT. They are used for hot flushes, for vasomotor symptoms, for dyspareunia and urethral syndrome. The long-term uses of HRT for osteoporosis, cardiovascular disease, and Alzheimer's disease. Then how to start this HRT? It must be given in lowest effective dose for minimum duration, and most benefits are seen if started in early menopause, that is less than 10 years of menopause, and starts with low dose estrogen and increase after 4 to 6 weeks if symptoms persist. First line drug is oral estrogen, and we can use transdermal preparation of estrogen if there is risk for venous thromboembolism. And in case of hysterectomy patients, that is uterus is absent, in that situation we can use estrogen only preparation. And intact uterus, we can use combined preparation of estrogen and progesterone. So when to stop HRT? Uh, Most guidelines recommend safe up to 5 years. There is no clear consensus on how to stop the therapy. Then what are the benefits of HRT? For most symptomatic women, the use of HRT for 5 years or less is safe and effective in women less than 60 years. It reduces vasomotor symptoms, it improves the quality of life, improves urogenital symptoms, improves mood change, reduces osteoporosis, reduces cardiovascular disease, lower risk of colorectal cancers, provided all these drugs should be used before 60 years, and decrease the Alzheimer's disease and dementia. So to conclude this topic, menopause is a clinical goals during menopausal transition are to optimize women's health and well-being during and after this transition. This is an excellent opportunity for comprehensive health evaluation. Because of increasing life expectancy, osteoporosis is fast becoming a global problem in the elderly. So maintain an active and healthy lifestyles. Never too late to start exercise. Regular calcium and vitamin D3 help. Bisphosphonate is the first line therapy. HRT in selected postmenopausal patients less than 60 years. And current guidelines should enable clinicians to feel more confident about offering HRT to eligible women. They should also be able to help women to make a more informed choice regarding their treatment. Thank you.
Thank you so much, ma'am, for giving out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants during the practice. As I can see, we have received some questions. With all your permission, shall we take these questions, ma'am?
Yes, yes, yes.
And the first question is, ma'am, from Dr. Agarwal. He is asking, how do you select appropriate candidates for HRT based on age, menopausal symptoms, medical history, and risk factors?
Provided first is S, she should be less than 60. Then she should not have any risk factor like breast or any risk factor like thromboembolism. There is no risk factor of cardiovascular, no risk for stroke. In that situation, we can give this, and we can use for short period, and it is given in low doses. And during that period also we have to do follow up, like we have to do the pelvic examination, we have to do pap smears, we have to do breast examination, like this.
Thank you so much, ma'am, for sharing your insight on this question. We will be taking another question, ma'am. How do you approach the discontinuations of HRT in women who have no longer required treatment, and what are the potential withdrawal effects?
As I was telling in one slide, there is exact no idea when to stop and after how many days it is stopped. There are several studies. So in one study, it is clearly told that we can give up to 5 years, and we cannot. There is no need to do gradual withdrawal. We can stop it sudden, and we have to start as early as possible in the menopause, whether the if she is having premature menopause, whether the lady is not having the menopausal features also, in that situation we can start this, and but we have to stop before 60.
Okay, thank you so much, ma'am, for sharing your insight on this topic, ma'am. I definitely think this session knowledge is going to help all the participants who have joined the entire session, ma'am. Ma'am, as there is no more question, ma'am, with all your permission, shall we conclude this session for today?
Thank you.
Thank you so much, ma'am, and hope to see you again with different topic in future also, ma'am. And thanks
Yes,
once again for taking out your precious time here. Till then, take care of yourself, ma'am. Thank you.
yes, thank you.